This episode of Common Health is brought to you by Reg Lantern. Reg Lantern is a straightforward and easily understandable software platform built to assist community health centers in staying compliant so they can focus on serving their patients rather than paperwork. For health centers that are serious about achieving, managing, and maintaining compliance, Reg Lantern provides a comprehensive approach and is an affordable and valuable solution. Reg Lantern can help your health center. Contact them today at reglantern.com. That's REG, as in regulations, lantern.com. For special discounts, mention that you heard about Reg Lantern on the Common Health podcast.
Hello, and welcome to Common Health, a podcast brought to you by the Virginia Community Healthcare Association, or VCHA. I'm Tracy Douglas, VCHA's CEO, and your host for this episode. On Common Health, we discuss all things community health in the Commonwealth of Virginia, amplifying the voices of those who are served by community health centers here and those who serve them. Hello, listeners, and thank you once again for joining us. Our Common Health podcast that we bring to you from Richmond, Virginia, sponsored by the Virginia Community Healthcare Association. And we're just so thrilled that you decided to hear another episode, and we try our best to bring you common folk stories, right? So that you can hear what other people are doing, how they're living, how they're taking care of themselves here in the Commonwealth of Virginia, but also we hope that what you get from this is, as you hear their stories, that you can relate in some form or fashion. And as always, we do our best to bring you fascinating stories. And I have to tell you, I personally feel that this particular guest that we've got joining us today is pretty phenomenal. He's daggone cute, and that's because I birthed this person. And this is my son, Richard Wheeler. We call him Alec, A-L-E-C. And the reason why we decided to bring Alec on is because he's made the decision to change course in his life and seek out a degree in medicine. And I just really thought it was good for you all to hear his experience, why he decided to get into medicine, talk about his experience going to medical school, and then talk about his future. Because I think that as I'm bringing his story to the table here at Common Health, that this also resonates with other students, medical students out there, or individuals that just completed their training and they're thinking about seeking out working and taking care of individuals in communities and figuring out which way they want to do that in this journey of theirs. And Alec, I just want to say thank you for agreeing to come on this show and allow your mother to be able to interview you and learn more about your decision to go to medical school and what it's been like and what do you see in your future for yourself as well as a lot of your colleagues out there. And so what I want to do is first, if you could just share with our audience, talk about who you are and what has been your thought process up to the point that you decided to do a course change in your life and go into medical school?
Yeah, absolutely. First off, thank you for having me on the show. A little bit about me. I was a bio major and chem minor in undergrad and always had an interest in healthcare. And then just watching you and your career with the community healthcare side of healthcare, I've always been interested in just health and trying to get more into the community. And I felt like there was an intersection between my interest in science and then community engagement. And I thought that would be possible. The federal government working for the CDC or health or HHS or possibly do med school. And so after undergrad, I went down to Duke and got a master's in science, but it was a focus in public health. And so I got exposure to different aspects of healthcare. And I was interested in the community side of it, also the administrative side of it, and a little bit in the patient care side of things. After I got my master's, I then worked for HHS in DC at the headquarters. And I worked on a few projects around just a national awareness around the importance of mental health and just well-being amongst our communities, particularly in minority and rural centers and areas. And during that time, I felt like I could have more of an impact as a provider. And that's just from my perspective personally. And so one of my mentors from my undergrad had always been throwing around the idea of me applying to med school. And she went to a school in Philadelphia. And so I applied there and got in. And I felt like going down this provider perspective or route would allow me to have a better impact with trying to just improve our community's understanding of health literacy and just everyone's overall health and well-being. So that's my story and what brought me to medical school.
You've watched your mom as you've been growing up working in the healthcare administrative profession. I've been on the hospital side, and now I'm on the community health center side. And I have to say, in the years that I've been working in here, I have seen it get progressively worse in the number of individuals that are taking the interest in getting into medicine and going to medical school, because there's so much involved in that decision, right? So can you tell our audience, we heard how you got here, right? But once you got in, what kind of emotions were you feeling? What were you going through outside of you adjusting to medical school, right? But what were you saying to yourself once you got in and were actually going through the training?
Yeah, I think one of the biggest adjustments for me as a non-traditional medical student, I think the average age of an incoming medical student, M1, is like 26, 27. And I started at 27, 28, so a little bit older. And one of the things that I didn't realize was the immense sacrifice that people that go into medical school and then off to residency, what that's like. And I had friends that went down that road, and I saw they'd be like, oh, I can't do this, I can't go socialize. And I didn't really understand it until I was now in that space. And so I always just not warn people, but just when I talk to people that are interested in going into medicine, make sure you can't see yourself doing anything else, because this is such a sacrifice to your personal life that you should just really think this through before you make this decision. It is a very rewarding and cool experience, and I love it, but people should really just think it through, because medical school is very challenging in different ways. I think academically, it's very hard because you're getting thrown so much information at one time that you're expected to know. You have to take board exams. And then also just like your personal life and your mental health at times can go up and down. And that's just naturally just how it is. You could literally ask every person in medical school or residency or fellowship, there's going to be serious ups and serious downs. And that was always interesting. And it's still a conversation that we have amongst our peers about how we're being trained to make people or get people healthier almost at the expense of our own health at times. So that's why it is really important to, as best as you can, stay as healthy or active as you can, stay as balanced as you can, because of just the sacrifice that goes into this.
And Again, I'm a little bit more closer to what you just described with regards to what you've personally gone through. But I think one of the things that really stood out in my mind was, and you and I have had this conversation since you entered medical school, but I've also witnessed it from you as well as some other individuals that have been going through medical school, is you used the word a tremendous sacrifice. And you talked about socially, you talked about what it does to you physically and mentally. But one thing you didn't talk about was the financial piece. And can you talk to us a little bit about what does this do to you financially too? What's the commitment and the sacrifice that you have to make in order to get you trained up to be a physician?
Yeah, that's a really important conversation that oftentimes I think people going into this space don't fully understand until they're in it. But on average, a medical student is looking at $300,000 worth of debt that they're going to be facing once they're done their training. And then med school's 4 years, and then residency can be 3 to 7. And then you could do fellowship on top of that. And when you're in residency, residents usually make between 55 to 70,000. And then fellowship, that can go up. Each year in residency, you make more money, but it's definitely not a lot when you're in your training. And then on top of that, we have to take board exams throughout your education and training. And those have to be paid for essentially out of pocket. And those range from at minimum $500 to $1,000. So the financial burden is a lot. And I think because of that, oftentimes people in med school or residency can make a decision on their specialty based on the salary, just because you're putting in upwards of 4 years of undergrad, 4 years of med school, and then let's say 4 years of residency. That's 12 plus years of education and training. And then you're coming out with $300,000 worth of debt or loans. You want to go into a field where you're able to financially be able to live somewhat comfortably and then also pay off your loans. And so you'll get I'd say it ranges of what people are interested in. There are people interested in primary care and family medicine. I wouldn't say it's a lot. I'd say maybe 40% of people are interested in those spaces. But a lot of times people make a decision on their specialty, one, in what they're interested in, but also two, just the financial aspect of being able to pay off your loans and debts.
And we'll talk a little bit about what you decided to, or at least what you're eyeing right now. But for what we do here with the organization that sponsors this podcast, Virginia Community Healthcare Association, that organization has a membership that's predominantly community health centers. And community health centers see patients no matter who they are, what they look like, and how much they can pay. And when you look at the services that community health centers provide, it's mostly primary care. And audience, for those of you who don't know what primary care is, that's your everyday doctor, your internal medicine doctor, possibly your family practitioner. For those of you who are seeing, you're a female, you'll see a GYN, or some of our community health centers have dental practices or pharmacies. So it's really, I think, services that everyday Americans need to access, right? Every day. And so when you look at, I think I was reading a statistic a little while ago that said that back in 1994, the number of students, medical students, individuals entering medical school at that time, it was like a 25% number of those individuals that had an intention of getting into primary care in internal medicine or family practice. The 2022 class, that was your class, and they did another survey. It went down to 17%. That those 17% of your class colleagues have an interest in getting primary care. And right now, the number of primary care providers is continuously shrinking because you're seeing many of them getting older and they're retiring. And so that being said, what does it take for a community health center to attract a student, someone who's just now getting out of training, ready to start working, just made the decision to get into internal medicine or family practice? What is it that it takes for our community health centers to attract your colleagues?
Yeah, I think a few things. One, like, you're always naturally going to get those people that are like pro, like just like nonprofit community health centers that are just passionate about community healthcare. And that's a lot of that 17%. But then if you're trying to recruit people that are in internal medicine folks or even primary or family medicine people, like, why would they choose a community health center over an employed hospital position or private practice? I think oftentimes, just from what I'm hearing from my friends or even myself, it's really important. Lifestyle is very important to us.
Wow.
And we hear horror stories about the old attendings, how they had to work even after residency 70, 80 hours a week post-residency. And that isn't of interest to people in our generation now. And so I think having that work-life balance is really important. I think we understand that we're going to have to work probably more than 40-hour weeks, but no one wants to work 70-hour weeks post-residency or fellowship. That's one thing. And then also just making sure that the administration is listening to your needs and making sure that you're okay and you're happy with your salary and just like your well-being. I've heard from friends who do work at employed positions or academic centers, and they feel that they're not listened to by administration. That's another thing. And then also too, I think just making it competitive salary wise. If someone has to pick either working for a community health center or private practice, yeah, it's definitely going to be a little bit more enticing to that young doctor who's being offered maybe more money for a private practice firm than working for a community health center. But then I say that even in the same sentence, I do know people that are just very passionate about community health, and that doesn't matter as much. But like you were saying, that percentage is clearly shrinking.
Mm-hmm. So, we have many community health centers that are located in the rural part of the Commonwealth of Virginia, like many community health centers in this country. And so you talked about lifestyle. And so how are you defining lifestyle, and how can you get that lifestyle in a rural community?
Yeah, I think going off my last point is just the importance of being heard by leadership is really important. My colleagues in med school or residency and fellowship go through so much. It takes the education and training takes so much out of everyone. And it's also very rewarding, and I love it. And everyone's very passionate about it. So I don't want that to be misconstrued, but it does take a lot out of you. And people's mental health is really important. And they stress that even at a foundational level in our education, we have weekly seminars about making sure you're keeping up with your mental health and making sure you're going to your doctor to get your vaccinations and exercising and having balance, because they understand how grueling this is. And so I think they try to set this foundation now before you go into residency, where your hours get even worse. And even there, they have different things in place to try to just emphasize the importance of well-being and mental health. So that is really, I don't really know if location matters. I think if you've got an organization that truly listens to their providers and offers them a decent salary, that I think is attractive for young patients or young doctors. And then also too, we get exposed to the breakdown of like the average salary for different specialties. And oftentimes what goes into that is location. So if you work in a more rural area where there aren't as many providers, you can negotiate a higher salary because you're of more demand. So that's also another thing that can be attractive for some people.
One of the things that when we go out and we help community health centers recruit for providers, and one of the things that some of these candidates have pointed out to us is it's been interesting how you said about the salary, matching up the salary with the area. And we hear that, yeah, the salary may be agreeable to that candidate, but yet when they look at the area itself, as far as things to do, right, they worry that there's not enough to keep them engaged, although they will be practicing medicine, and that thrills them that they'll finally be practicing medicine as a practitioner. They still worry about, okay, so I leave at the end of the day, what am I going to do?
Yeah. I don't even know if I have an answer to that, because that's just a location issue that I know at the end of the day, yes, salary is very important, but if you're not in a location that has much going on, that's hard to recruit people to those areas. And like I said, there's definitely going to be people that are interested in that and that are just passionate about community health or rural health. But even then also too, patient population, I think, is also something that you have to take in consideration. If you're working for a community health center in inner city Pennsylvania or Virginia, it's a different demographic than if you're working in rural Virginia, and having to deal with those complications and adversities where we have to go do once a month, we go to a rural community hospital and go see a patient. And I've had interactions with patients where they have high cholesterol, and there's somewhat easy fixes to high cholesterol. If people work on exercise or their diet, those can be things that can be achievable if people are willing to work on those. And then sometimes you have to prescribe medications like a statin, for example, for someone with high cholesterol. And so I had a situation with a patient, and we had talked to her about taking a statin to address her high cholesterol. And she had told me and the attending that she's never taken medications before and that she doesn't trust the healthcare system. And historically in her family, they'd never gone to the doctor's office really. And she was forced to essentially go see us that day. And that's a very real thing, especially if you're in like a rural area. And it's understandable. I can understand where she's coming from. If that's not something you have historically done, we're going to the doctor's office, which can be a very scary thing. And especially today where there's a lot of mistrust with healthcare to begin with, it can make your job harder if you're working in a rural area or an inner city area, for example.
I want to change it a little bit here to talk about expectations from you coming out to work, and then expectations from the community. You hit on something when you were just talking about the way that people perceive healthcare, right? And I think that's a result of COVID and the mistrust seemed to have gotten deepened. It was there, but it really seemed to have gotten deepened. And so we find in the community health centers that there are people in the rural setting, and I have to say in the urban setting, that we see that don't trust providers and don't think that the providers have their best interest. How do you think you and your colleagues are trained, right, to help deal with that?
Yeah, I am actually a part of an admissions team at my school on trying to just better diversify medical school. And that doesn't even mean from a race and ethnicity perspective. But there's been a shift, I think, in the admissions process with, at least at my school and some of the schools that some of my friends go to. They're not looking for super book smart applicants. Yes, you have to have the grades and the test scores, but on your interview day, a lot of our interview days are around just conversations, and admissions folks and some of the physicians that they have interview applicants just want to see if you can relate and have a conversation. And I think it's really important now that young medical students and people in training are able to relate to their patients and be able to have a bedside conversation. I have a class on bedside etiquette and communication, and it's trying to teach us better, more innovative ways to connect with patients, which can be hard for some people who might not have had interactions with someone from a rural area or from an inner city area, or a person that is of the LGBTQ plus community. And these are the patients that we're going to be seeing. And so it's extremely important to be able to relate and have a conversation with your patients so they can find commonalities and actually trust you as best as they can. And I know for me, I've had experiences with patients where even just seeing someone of color, and then my patient being of color, has kind of brought that guard down a bit, and then having more of a trust in me. And we see that in statistics all the time in our education, is that the importance of finding commonalities between the provider and patient perspective just allows for better health outcomes.
So I want to get back to your training and your interest in what you want to do. So what's your interest and why? And then what steps are you taking or planning to take to further develop your skills and knowledge in that desired specialty?
Yeah. So I am interested in urology.
Urology?
Yes.
Not primary care?
No, not. You'd think having a mother who's been in the community healthcare space for so long that I would have gone down that route. But no, I'm thinking urology. I really like the procedures that they do. Particularly, I just submitted an abstract for publication on the impact that misgendering has on people that are trans, our trans population patients, and how we can better address the barriers to care that those patients face to improve better health outcomes with that patient population. I think I'm interested in subspecializing either in men's health or trans care. And a part of that too that went into that decision for me is they do have decent work-life balance. Some of the more competitive specialties are so competitive because they have really good work-life balance. And some of those are like anesthesia, PM&R, plastic surgery.
What is PM&R?
PM&R is physio and muscular rehab. So it's basically someone that does a lot of sports medicine, essentially. And then, yeah, so those are the more competitive ones. And because of that, you have to do like research and get publications in order to match into those specialties. So in medical school, I don't know if I said this before, but it's 4 years, and then you take boards your end of your second and then your third year. And oftentimes, depending on how you do on your boards, then on your rotations, and then how much research you have, that can determine what specialties you go into. So I was fortunate enough to I was accepted into a fellowship program out west for my break in between my first and second year, where I worked with urologists who specialized in pelvic female medicine, and then trans care urologist, and then men's health urologist, and was able to do some research with them. And I will continue to do research with them for the next 3 to 4 years until I apply to residency. And during that time, I'm just working on publications and shadowing with different urologists through my program. And this program is essentially a program to help diversify the urology space. Because like I was saying, it's one of the more competitive specialties. And historically, it's been, frankly, white men. And so there's been a push to put more people of color, women, and trans providers in the urology space, just because we see how important it is to have providers that look like their patients and what impact that has on their care.
So how do you see urology aligning with your own personal values and goals?
Yeah, a little bit of backstory too on my interest in urology is my dad had prostate cancer, and being a part of that experience sparked my interest. And then in medical school, you take classes on the reproductive system and the cancers that can occur in the reproductive systems. And one thing that's really prevalent in the African American male community is prostate cancer. And it's oftentimes something that can be easily screened for. And if it's caught early enough, it's pretty treatable. But unfortunately, people just don't get screenings. And that confused me and just really stuck with me, because I was like, if this is something that is so easily fixable, or you can just do a quick screening, where's the disconnect between the African American male population and the healthcare system? And it goes back to just that mistrust at times. And in school, I helped develop a group of guys go to inner city barbershops, and we do blood pressure screenings and just ask them a few quick questions about if they see a primary care doctor, when's the last time they've had blood work done, have they ever had a PSA test before, in hopes that we can just test for people's blood pressures and just let them know if they have high blood pressure or not. But then also two, hopefully being in spaces like a barbershop just shows more the human side of the providers, just to show like, okay, you've got this young guy's in here. He also gets his hair cut here. Maybe this is something I can consider. So hopefully we can find ways to reach to different demographics through that. So that was, I think, where my ultimate like passion and interest lies, is just finding ways in the urology world that I can improve the healthcare outcomes of some of our most marginalized communities. Yeah.
And can you share with your audience any mentors or role models who have inspired or influenced your career aspirations?
Yeah, I have a few. I think first, one of them would definitely be you. I think just growing up, seeing your hard work and dedication to community healthcare pushed a lot of my passions and my morals and goals career-wise, but then also personally. I think I would start there, and definitely my father as well, with him being an Episcopal priest and just seeing his interest in the community. That definitely laid the foundation for me of wanting to be in the community and using my skill sets to try to make a positive impact. And then within the medicine space, my mentor out in UC San Diego, who I was accepted through the program with, Dr. Santiago Lastra, is a female health reproductive urologist who really tries to push the importance of diversifying the urology space. And she's taken me and a few other students from other medical schools across the country under her wing, and all of her research is funded around community health and improving health disparities. And then my other mentor is Dr. Jennifer Anger, who is a urologist in California at UC San Diego, who specializes in trans care, and she does trans procedures for patients. And I think originally I was always interested in urology, but then once I was partnered with her, that kind of opened me up to a whole new world of just the importance and the impact that work does for certain communities. We would have patients fly in from all over the country, particularly in some of the southern states, who couldn't receive care, get the care that they needed out with Dr. Anger. So I definitely credit both of my passions in the urology space to Dr. Anger and Dr. Santiago Lastra, who had a huge impact on me.
And, as I became more and more familiar with medical training through you and what you've been going through, had options on what school you were going to go to. And can you just talk? You go to the Philadelphia College of Osteopathic Medicine. And when you are done, your acronym at the end of your name will be DO, when so many people have seen MD. Can you tell us the difference between osteo and allopathic medicine?
Yeah, that's a good question. Yeah, so there's the allopathic route, which is MD, and then there's Doctor of Osteopathic route, which is DO. And so the education is the same. We take an additional course on a holistic approach to the body. We take the same board exams, and we still go to the same residencies and fellowship programs, and we're both board certified to do all the same things. But during your education, the DO students take an additional course on just more holistic approaches to medicine. You learn all your basic sciences and the pathologies and the physiologies. And then you also take just an additional class on how you can relate all the components of the body together as one. And there's different manipulation procedures that you can do as an osteopathic physician that the allopathic physicians aren't educated on, but they can receive education on that in their residency if they want to. So it varies. I think once you finish your education, depending on the field you go into, will determine how much you want to incorporate your osteopathic manipulation techniques. But yeah, it's a really interesting perspective towards a more holistic approach to the body. But at the end of the day, you take the same board exams, you go through the same fellowship and residency match process, you have the same salaries. There's no discrepancies there. It's just during your education, you take an additional class.
And bottom line, you're scientists, right?
You're physicians. You're scientists, right. Physicians.
Scientists, yeah. Physicians, right? Yeah. Before we close out, and I just want to say thank you so much, son, for coming and agreeing to being on this show. But before we close out, I want to go back to the financial piece, right? And when this is all said and done, and the debt that you and your colleagues will carry. And I think you even said that you had some colleagues that are going to be taking their boards and they're going to actually have to borrow money, right? They're going to have to maybe take out some loans, additional loans, just to cover the costs of their board exams. And then I believe you and I know of physicians that have been practicing for almost 30 years and are still paying on their loans. Do you think that is a sacrifice that you should take on to make that decision? When you make that decision to get into medicine and to take care of someone's health and their life, do you think going in that kind of debt and the sacrifices you have to make physically and mentally, do you think you should make that kind of sacrifice? Do you think people should do that?
I think, do I think it's fair? No. I think there's
Why don't you think it's fair?
I think one, there's just this expectation that we are supposed to take out loans of hundreds of thousands of dollars, and then we have board exams we have to pay for that, like I was saying, can cost from $500 to $1,000. And that's just the way that it's always been. And I hear that oftentimes from people that are farther along in their education or training. They're just like, well, that's just how it is. And I think there should be more conversation around that. I don't have a solution because I do understand how expensive it is to put 200 people through a medical education. But I also, in the same sense, don't think it's fair that we're expected to just take out all these loans and just bear this burden of hundreds of thousands of dollars worth of debt. And so I think more conversation needs to be had about maybe more scholarship opportunities or government funded programs that help students pay for med school. Because even there's different programs like the HSPS scholarship, which is like a health profession scholarship for medical students. I'm not sure if it's offered to other health professionals. It might be, but even those can be pretty competitive. I've got a good buddy who is like top of the class and is in incredible shape, just ran a marathon and killed it. And he didn't qualify for the military scholarship because he has diabetes, type 1 diabetes, which he was born with. And I'm not trying to knock that scholarship program, but that's just the reality that we face, where this is a student who was looking for a way to fund his medical education and didn't qualify for a program.
Just because of his current health condition.
Yeah. But there are programs out there, like the VA has a program that will sponsor medical students as long as you give back time and work for their health systems. But yeah, it's definitely a burden, a serious burden, because then, like I was saying, even when you're in your training, you're not really making as much, comparatively speaking, for the hours that you're working, with it being like 60 to 80, sometimes even more than that, hours per week. Yeah, I can definitely agree in terms of there needing to be some sort of change. And I think that starts with just more conversations around people understanding the financial burden that this actually has on medical students and residents.
Audience, Alec talked about one option that individuals have to help fund the expense to go to medical school. There are other things like the National Health Service Corps, where you have many individuals that are working in the community health center space are National Health Service Corps scholarships. But again, speaking of those requirements, there are requirements and they are competitive. And I want the audience to know that there are options out there to help assist. So that concludes our time together, son. And I just want to say thank you. You've enlightened me on some things today. So I hope that maybe when you get out and you're getting into your residency and or fellowship, we can have you back and we can do a pulse check with you and see where you are. I know that you just finished up a segment in school, so you've got a little bit of a break. What segment was that you were?
I just finished up cardio palm. We're halfway through it, and you take your education. Our education is breaking up in blocks. So you'll do like a block of cardiology, then a block of renal system, a block of neuro. And so we're finishing up the blocks, and I finish my classes in May, and then I'll be done my first 2 years. And then I study for boards, and then third year is rotations, and then fourth year is applying for residency.
Okay. All right, audience, again, I want to say thank you for taking the time to listen to this episode of CommonHealth. We really appreciate it. And Alec, I love you, son.
Love you too.
I want to thank my guest for joining me today. And thank you to all the listeners for tuning in to CommonHealth, brought to you by the Virginia Community Healthcare Association. If you enjoyed this episode and you'd like to help support CommonHealth, I encourage you to hit subscribe button and share it with others on social media. Leave a rating and review or visit our website at www.vcha.org. This is Tracy Douglas Wheeler, and thank you again, and I'll see you next time.